Thank you very much for the kind invitation to present today. I apologise that there are quite a lot of slides, so we'll be going through some of them relatively quickly. I don't want to bore you too much with the science, but just to give you an overview. I apologise, I won't actually be mentioning the OBE at all in this talk, although it's a massive career highlight for me. It's mainly about, the key projects and the challenges and rewards of building a successful research team. So I'd like to briefly go over the perceptions of plastic surgery, what motivated me to enter plastic surgery, the value and potential of plastic surgeons in research, building career in the Research Centre, three major projects covering very different areas. One will be lab-based 3D printing, one will be quality improvement and improving cancer management using AI, and the last one is a humanitarian project. And there'll be a brief talk about the challenges, which I'm sure will be the same to any of you in the audience with a very demanding career. So perceptions of plastic surgery are in the media all the time. They really aren't true. The majority of plastic surgeons in the UK don't do any of this. It's normally unregulated, non-medical practitioners. The reality, apologies for these images after lunch, but it's just to bring the challenges of how hard it is to mix a surgical career with an academic career. We have to deal with lots of trauma, upper limb trauma, lower limb trauma, skin cancer, and wounds. And this is very much my motivation for doing it. I'm a bit of a history geek. I was really interested in World War I, World War II. Some of you recognise these images from the Guinea Pig Club. I have a couple of people have mentioned lived experiences, which is really important. My brother was born with a cleft lip and palate, which had a huge impact on obviously his life, but also the family. And I was really impressed with how the medical practitioners dealt with that. Historically, again, this has been something that's been around for a long time. Although plastic surgery is a new medical specialty, it's actually been practiced for hundreds and thousands of years, moving things around the body. And I was really keen for my research interest, obviously, to marry up with my clinical interest. I admit I have had a privileged educational background, although I was the first member of the family ever to go to university. So I've always been, felt really lucky to be in these environments. And I've been fortunate. I've always been really focused. And I decided very early I wanted to be a surgeon. I want to be a plastic surgeon. And I say this to a lot of my trainees, that it's very important to decide early. And I haven't regretted my choices at all. Because I've been privileged to treat patients of every age range, from the cradle to the grave, and also, from the head to the toe. And it leaves plastic surgeons in quite a good place to do research, actually, because we deal with every single tissue type. So on a scientific level, that's really useful, but also open, to lots of innovative solutions to lots of areas. And we also cooperate with a lot of other surgeons as well. So it's a really, really good environment for research and innovation. We've been really good over the years at moving bits of tissue around the body, either as a skin graft or as a flap. It's only been the past 50 years which we've had really exciting things like microsurgery and transplantation, particularly face transplantation, which has grabbed the public imagination. And I can say some of the follow-ups for that have been absolutely amazing. And we're moving into the era which I'm interested in, which is tissue engineering and 3D bioprinting, so the ability to print and to grow human tissue in the laboratory. Loads of people, particularly junior trainees, ask me how I got to this stage. And it'd be the same, for any of you that have been successful in your career. There's lots of ways to reach the goal. The one thing you can't get away from, and again, this has been mentioned before, is hard work, sacrifice, and being able to deal with setbacks, failures, etc. For every success, there's been 2 or 3 real disappointments. I've also been lucky to travel the world. It was relatively unusual as a trainee in Wales to travel to lots of locations, but I really wanted to see what was out there in terms of the best practice throughout the world, both in a clinical setting and an academic setting. So I've been fortunate to have trained in the UK, USA, Australasia, Asia, and more recently, Africa. This really sticks in my head. The first, and I won't name him, the first consultant I had when I came as a trainee, because Swansea was such an amazing place near the beach. He said it's a graveyard of surgical ambition. people settled down and just enjoyed their life. But that really spurred me on, and it's always been my passion about putting Wales on the map in terms of surgery and plastic surgery and research. And the secret to my success partially was working really hard when I didn't have to. So this bit circled is the middle of your training, where you're just normally learning your craft specialty and operating. You're not bothered about research and publications. I managed to publish almost 100 papers during that time, in part due to traveling the world and visiting some of the top units in the world and collaborating with them. When I was appointed as a consultant, it was unusual. There aren't many academic plastic surgeons in the UK, and there wasn't any, there were no substantive academic posts and no formal collaborations in Swansea at the time. But there was really good potential, really nice place to live, really good, busy clinical training plastic surgery unit, and they'd come very high in the GMC training survey. So it was nice to be able to recruit people to the environment. Also, Swansea is an ambitious university, really good new medical school, and they had 4-star facilities, particularly the Centre for Nanohealth and Institute of Life Sciences, and the plastic surgery department were very supportive in the early stages as well. And within 10 years, had built it into something of a hang gods of Babylon compared to a desert in terms of academic plastic surgery, with lots of new collaborations, lots of team members, and lots of strands to the research. This is a couple of years ago. Objectively, it was the biggest plastic surgery research group in the UK by some way, ahead of London, Oxford, and the normal, Golden Triangle institutions. Been fortunate to have generated quite a lot of research income over the past few years from a range of sources. The WCAT scheme, the Welsh Government have been very supportive. Health and Care Research Wales, the Scar-Free Foundation, and lots of professional bodies. The investment and support yielded increase in publications year on year, not just quantity but also quality, because metrics are very important, as everyone knows, when you're applying for grants. We've been increasing the impact of our research year by year. And this all culminated with the opening of the Research Centre by the then Countess of Wessex and now Duchess of Edinburgh in March 2022, which really supercharged the research to allow a programme manager and full-time postdoctoral researchers to take forward the research. So I'd like to focus, if there's time, just on 3 key projects. There have been a lot more of these over the years, but the major ones are 3D Bioface, which is a laboratory-based project, which is 3D printing human tissue for facial reconstruction. The RESET programme, which is to do with improving skin cancer management, which will be translational to other oncological areas using artificial intelligence. And also a humanitarian mission, which is called SPARK, which I will talk about briefly later. So the 3D Bioface project is about 3D bioprinting noses and ears, for use in reconstruction. The traditional approach now is to carve the ear from the ribs, which obviously is quite technically demanding, takes a long time, several hours a child's on the table, and there are complications and risks involved in that. So it'd be really nice to be able to produce something in the laboratory to reduce the operating time, reduce the risks, and reduce the complications. And it will also reduce scarring and morbidity. To do that depends on cells, the biomaterial, and the platform technology of 3D printing. This is something over 10 years ago which wasn't really done, to be honest. Because I was interested in complex 3D shapes, particularly ears. We made our own bioprinter with the help of the engineers. It was like something out of Robot Wars. It's incredible to see how it developed since then. But we actually won a medal from the Royal College of Surgeons because it was the only surgical team to be using them in the country at the time. And in time, it became clear that this was one of the futures of surgery. And it was one of the 8 great technologies that the UK government had supported in terms of regenerative medicine and 3D printing. I won't dwell too much on each of the scientific bits, but we were really keen to choose the right cells, because I'm not sure if you're aware of, the well-publicised problems with the tissue-engineered tracheas, which killed quite a lot of people, and that was using a non-tissue-specific stem cell source, and it was a non-natural biomaterial. We tried to focus on tissue-specific, so we're using cartilage to make cartilage. It seems simple, but there's lots of people using fat because it's easier to access, and also using induced pluripotent stem cells, which you have to force down a particular cell line. The problem with the tissue-engineered cartilage was very much in my mind when I decided to focus on a natural biomaterial. So we did due diligence, doing reviews on what the appropriate biomaterials were appropriate at the time. And we published on the characterization and sterilization of these. And we actually focused on a pulp-based nanocellulose, so from trees. Nanocellulose is amazing, incredibly strong, resilient biomaterial, which is very tunable. And we looked in, it was very hard to get a biomaterial at the time which could print and hold its shape. But we were pleased with the early promise. We looked at rheological studies with the EPSRC Centre in Swansea, and we did our own experiments and showed that it was very printable. It wasn't quite as firm as we needed it to be, but it needs to, when we implant it, it needs to survive under the skin, which can be quite tight. So we added hyaluronic acid, which some of you may know is an injectable. They use it for lip fillers and for other fillers. And that seemed to strengthen it, and the cells liked the material more. So cells grew more in it. We could make better shapes, and it was more resilient. The downside was the manufacturing process wasn't as sterile as it could be. So when we did sterility studies and long-term growth, there was too high a risk of infection. So we wanted to use our skills of nanocellulose experience, which I believe is a very good biomaterial, with an ultra-pure source, which is GMP compliant. So we're working with Tunicell. It's a tunicate-derived nanocellulose, so the same structure from a different source. We've done characterization studies, and we've shown non-inferiority in terms of biomimicry, or how much the cells like it, and how strong it is, and how we can print it. Underpinning this is the platform technology of 3D bioprinting, and we've seen a significant evolution over the years. We're now using a BioX, which has three nozzles. It can be temperature controlled. We can sterilize it, so we can print in close to GMP facilities at the moment. It's actually really hard to print complex shapes bioprinting-wise. It's easy with plastics and metals. You should just build from a base upwards. But when you've got complex 3D shapes, you've got complex overhangs and folds which can't support itself. So a real step forward over the past couple of years. We're collaborating with the Birmingham laboratory, and we're using the SLAM technique, which is suspended layer additive manufacturing. So it's printing into a dynamic mold. So it's a structure which is held in a mold, which has loads of biological advantages, but it also means we can print 3D structures, which really can be personalized. So we have printed patient-specific, clinically relevant tissues so far with our biomaterial. We've just done some preliminary animal models in collaboration with Harvard Medical School, where I've put them into rats. The early results are good in terms of they don't promote too much inflammation, so they're non-damaging to local tissues, and they seem to hold their form and structure. We need to improve the mechanical strength, because when it's implanted under the skin in a more hostile environment, then it will be more liable to be resorbed and to deform. So we're looking at different ways of improving the strength, using bioreactors, different cell culture environments, alternative cell types and cell seeding densities. So obviously funding is tight at the moment. I've had a few calls saying, America have started a clinical trial. And there was a big one called the Orinovo study, which has actually been pulled because it deformed too quickly. It wasn't strong enough. They rushed too quickly to clinical translation, whereas we're trying to take a stepwise approach and to leave no stone unturned. Next year, we're planning to do a larger animal model study at Harvard Medical School, and I'm quite confident that that will be positive. We're going to try and 3D bioprint, scale down ears and noses and put them into a rabbit. We're liaising with the MRHA at the moment, and I have a plan for first-in-human studies to limit the risk, but also work towards total ear reconstruction in a child, which is the ultimate aim. The other project, which I'm really excited about, is called Recept, and it's all about improving skin cancer management. In Wales, I love this slide because it gives you some idea of impending doom. But it means there's a significant increase in skin cancer cases in Wales, and there's a huge cost, an absolutely enormous cost. And some of our work has actually shown it's the highest incidence in Western Europe. We've worked closely with SAIL over the years and done some really nice work looking at the health economic burden. So we've looked at melanoma skin cancer, which is less common than non-melanoma, but it does kill lots of people, unfortunately. And you can see it's tens of millions of pounds cost to the NHS, tens of thousands of operation, hundreds of thousands of appointments. So just imagine the burden on NHS if that increases. We've also looked at non-melanoma skin cancer, which some of you may be more familiar with, which is things like basal cell carcinomas, incredibly common. People in the audience will have them. I've got blue eyes and I'm fair. I will almost definitely get one. We see thousands of these in clinic. They're massively underreported. We know that, and our research showed that. And it's hundreds of millions of pounds of cost if you're underreported. So just from our research, the reported skin cancers are worth over 200 million. They're impossible to measure. And I know from day to day that they are inefficiently managed. So how can we improve that? We've had some excellent talks on AI today, and I think it is going to be the future of healthcare. We've been looking into using AI to enhance delivery of cancer care and also to improve reporting methods. We focused on NLP, which is natural language processing, which in simple terms takes some text from a histology report or a clinic letter, and it will transfer it into readable, structured data that a computer can analyze, and then you can make, treatment predictions based on. And we published that showing that we could validate it on basal cell carcinomas, histopathology. I'll explain the impact of this later. This could have a big impact on the MDT, which is a multidisciplinary team where you get lots of experts in one room. So imagine the resource needs of that, people traveling from different locations, normally lots and lots of experience all in one place. But there isn't enough time to discuss the complex patients because of the increasing amount of patients there are, and they can't fulfill their secondary roles, particularly clinical trial recruitment. There's not enough time. The current MDT is not optimal, so you don't have key people there sometimes. Sometimes an oncologist can't come, sometimes a radiologist can't come, sometimes there aren't enough plastic surgeons, and the right information is often not used to inform discussions. So we were quite lucky in COVID, although it was a horrendous time. It made us really think how we need to change management of some of these things, and we started using virtual MDTs, which is a bit of a no-brainer if you think about it. Everyone doesn't have to travel and park in one location. We did a study and published it, to evaluate, the user experiences, so the doctor's experiences, and they all thought it was really positive. Obviously, the attendance was higher, and importantly, there weren't worse decisions made, if that makes sense. It kept the same level of sensitivity and specificity of decision-making. So we're proposing we can harness natural language processing, link it into national standards, and we can develop an automated clinical decision support tool, which will be useful in skin cancer, but also will be translatable to urology, to colorectal surgery, ENT, basically any specialty that has oncology at its heart. This really excited me because we present audits a lot in surgery. Normally a junior presents 200 cases of BCC. I think that was the biggest one published ever. Using NLP, we managed to publish 35,000 results and to see how many were taken out, what the margins were, and then we could look at what the high risk and low risk ones were. And we've also published, based on that process that natural language processing can be used to modernise a web-based model of care. We're working on a minimal viable product. We'll be presenting it to Health and Care Research Wales soon, but we believe there's massive potential to streamline care, save lots and lots of money, but most importantly for patients to get quicker treatment, which is evidence-based. And the aim of that is not only to give them quicker evidence-based treatment, but also to link them into clinical trials, which could enhance research in that field. So a complete diversion, something I never thought in my life I'd be talking about after 3D bioprinting and cancer, is something called SPARK, which is a Swansea Pansy Alliance for the Reconstruction of Care of Victims of Conflict-Related Sexual Violence. This isn't talked about as much as Gaza and Ukraine, but there's a huge war going on in the east of the DRC, which I believe is the most populated country in the world, and it's the richest country in the world in terms of natural resources. And there's lots of fighting going on about minerals. And this was a brainchild of the Duchess of Edinburgh, who came to visit an open unit, as I mentioned, in March 2022. In October 2022, she went to visit this incredible man called Dennis Mukwege in the eastern DRC, who's very prominent. He's one of the only ones that hasn't been scared to speak out about this problem. There have been multiple attempts on his life, and he can't travel safely throughout the world, even in his own country. He won a Nobel Peace Prize in 2018 for treating 100,000 ladies that had been the victims of rape with horrendous injuries and horrendous stories. If anyone has the time to watch City of Joy on Netflix, it's unbelievable. It's about, the ladies and the victims and the work he's done over the years. She's pretty hard to say no to, and then when you meet Dennis Mukwege, you think, I've got to get involved in helping this. So there's quite a lot of time and effort input. I managed to put together a scope of work to include surgery, research and training and capacity building. Made use of some of the local resource in terms of surgical training models, which has been funded by the EPSRC, and we've done really elegant perineal training models. There's a lot of problems with fistula formations, essentially holes that shouldn't be there, and huge functional problems in the perineal region. Quite soon after, I led a mission to the Pansy to meet Dr. Mukwege. We were really lucky that the British ambassador to Congo came from Kinshasa, which is a very long, dangerous journey. But she was really keen to see the work we were doing. It was really well supported by the Wales and Africa Grant Scheme, who've been fantastic. And it just showed the need of these people and the potential. This is one of the lowest impact papers I've probably done, but it's quite unique to have a member of the senior royal family as a co-author. But she actually, did input into this and, thought these models were excellent. She made some suggestions. I presented it to a couple of times. I didn't expect it to be used so excitedly on the first visit, but there were hundreds of people came and, they really found it of benefit. And we've gone on to get more funding from the EPSRC to develop this model even further. Now I've seen the surgery, I'm aware of what the challenges are. We're improving the anatomy to try and make it even more useful. The ambitious aim is to take it across all conflict zones, because it is prominent in Gaza, it is prominent in Ukraine and in multiple areas in Africa. The Duchess came for an update in Swansea, where we got Dennis Mukwege over and his team, and we had a discussion about how we could take this forward. We had a recent roundtable meeting at St James's Palace, which was attended by the FCDO, multiple Royal Colleges of Surgeons, Wales and Africa, Welsh Government, and it was a really positive environment for discussing how we can be really ambitious about this, which isn't talked about as much as it quite should be. An exciting part for me is capacity building and succession planning. So I met an amazing junior surgeon over there called Gloire, who actually visited me in Swansea for a month just before our last visit, and he's going to come back next year for a whole year. He happens to be the son-in-law, I didn't know, of Dennis Mukwege, and he found out about that relatively recently. but he is going to be the future of this, and I'm sure if we can equip him to train, it's going to have an impact on thousands of people. The recent visit, it was just a couple of weeks ago, we went, and I was very fortunate to be in theatre with Dennis McQuagey to help him with operation, and the Duchess of Edinburgh herself wanted to watch the operation. There's a really nice piece done in the Sunday Times, which is to increase awareness about the problem. It's been the highlight of my career to be involved in that sector, to be honest, and to see the effect it has on people is truly humbling. Challenges, we could all write hundreds of slides on the challenges of juggling such a challenging career. It's really hard to be a surgeon and an academic. It's hard to be either or. The hardest thing I found is building and managing a team, sustainability. I'm terrible if one of the good team members leaves. I'd be a terrible football manager. But if your star player just goes to a competitor, it's like, what on earth is going on here? How am I going to replace them? But I've been really fortunate, to work, and I've tried to show lots of photos of, colleagues that have worked in the team. And this success couldn't have been achieved, without all of our hard work and aligning the incentives. This is my favourite quote of all time, Winston Churchill's, success is walking failure to failure with no loss of enthusiasm. I'm always the same. If there's a failure or not that evening, I'm done. That's it. I'm devastated. I go to sleep. I'm not doing this again. Next morning, I wake up, I'm full on again, completely forgotten about it, and just going to the next challenge. I must be a masochist in some way. The hardest challenge I found is since I've had children, not spending as much time with them as you should. There's loads of acknowledgements, and this has been one of the highlights, is building a network of collaborators, colleagues, friends, and some of the successes, we talked about successes in the title. I've had multiple ones of this team that have gone on to win individual really prestigious awards. So there's something called the Honorary Professor for the Royal College of Surgeons, which is for all specialties in surgery. It's the most prestigious award. My team won it 3 years in a row from Swansea, which is unheard of. It's never happened before. Zita Jessup, Tom Jovic and Stephen Alley. The first two on 3D bioprinting and the third one on the skin cancer and the automated MDT. Zita won a Fulbright scholarship to go to Stanford to further her work. Steve just recently won the gold medal for Europe for his surgical subspecialty. And they've all gone on to do amazing things. They really are stars. And I think to be able to recruit them into Wales has been absolutely fantastic. Health and Care Research Wales has been a massive support, particularly Michael, Nicola, and others. They've always been there as a support and to advise and to make use of the resources, that we have. And the Scarfee Foundation, obviously, have been a major funder, and they've been very supportive as well. So I'd just like to thank everyone in the audience that's been supportive, and I'll stop talking there.